Hello, I'm Dr. Alan Malik, and welcome to this first webinar in our series on how to boost your integrated behavioral health program performance. In this first webinar, we're going to get into how to make your screening programs more effective. And get a little background here. Patient Tools is essentially an information processing company, and we're a bunch of engineers and IT people and so forth. And so we just come up with better ways to administer assessments and screenings and how to move that data around. And we don't get involved with the content side of these things. So we refer to ourselves as content neutral, meaning that we don't get involved with the license fees. That we really don't have a dog in the fight as far as, what are you going to question about and what are you doing? All we're really here is to help move the process along. So what we ended up doing here is we ended up creating a little study so that we could go to a conference for Collaborative Family Healthcare Association, their annual conference. And, the results are kind of interesting, so we thought we'd throw them out here first and kind of get them going for you. And kind of the premise on this whole thing is that we're using, if you're familiar with C.J. Peek's work, he has a model, a very simplified model for medical settings, which is really, really useful of basically saying the three worldviews are clinical, operational, and financial. And if you actually look at our webinars breakdown, you're going to see here that it's kind of that the first one is really about, becoming effective is really how do you solve that clinical side of things. The simplifying that screening process, which is webinar 2, is really around that whole operational aspect of things. And then making that business case really is you're going to leadership, you're handling the financial aspects of things and so forth, and making the whole thing work together. So let's get into it a little bit. In terms of being more effective in terms of your screening, the study is going to give us some real insight into, most everybody's using that PHQ-9 out there. And they're using it for a bunch of things, and we probably need to take a little harder look at exactly what's going on with that. But it really does have a role in detection, assessment, and monitoring. And I think you need to understand a little bit more about what the data is telling us to be able to say, maybe we want to think a little bit harder about how we do that. But the end of the whole presentation here today is really going to come back to you're not screening anywhere near what you need to be. And in reality, you can take any sort of screening, combinations of screenings or whatever environment you're in, and really kind of think of that more as a patient interview. And what really happens when you go from that process of a bunch of individual screenings over to how do we do this thing in an interview sort of style. And that's really what Patient Tools brings to the table. And so we'll get into that and give you some background on that whole thing as well. So let's get into it. So here's our simple study. We basically put this together as to be able to put together a poster for the Collaborative Family Healthcare Association meeting. And, they got the new poster format, which is really kind of cool if you guys haven't used that before, but it's kind of lays out pretty nice. And then, so getting down to it, the problem here is that, the PHQ-9 is basically, when you actually do the analysis, it's very expensive in the overall scheme of things. It's labor intensive and not all that effective unless you're using it properly, which most people don't. So, the big solution that we're going to come to, in terms of what the study is going to show us here, is that the use of the PHQ-9 as a pre-screen, or basically use the PHQ-9 as a pre-screen, and then add in some sort of automated in-depth assessment. And so in this particular case, we're going to be using a tool called the QPD, which is a quick psychodiagnostic panel. And it's really a psychological workup intended to be used in medical settings. So it kind of fits the bill here pretty good. And we happen to have a data set around it, so that's a good way to go as well. But what we're going to show is, how you can drive down those labor costs and produce some actionable integrated results and so forth. So I think you'll find it interesting. Going through the introduction of this whole thing, the big thing here is that your PHQ-2 or your PHQ-9 is a screening tool, primarily on that detection side. It doesn't really yield any sort of clinically actionable assessment information. It's just a measure of distress. And so all you can say is, well, I got something. So all you've done is you raised a flag. And now somebody has to go follow up on all that information. The problem with it is it's got high rates of false positive and false negatives, and in that creates a lot of work and actually kind of drives away your medical side because they lose confidence in it, which we'll get into as well. So what we want to explore here is how to use that PHQ-2 or PHQ-9 as a pre-screen. And so you add that in-depth electronic assessment, which is going to meet your clinical needs. And then we look at how we automate that, or we'll get into that in later webinars in much more detail, but we'll kind of lay out how you do that to meet your operational needs. And then you end up reducing your labor because time is a big item, especially when you're trying to meet a 30-minute session. And so we get that down, and that also helps us meet our financial needs. So the method we went through here, pretty straightforward. We had a data set from a FQHC up in Montana. There's an integrated behavioral health specialist up there that basically was more than happy to let us use his population level data. And what we ended up doing is we were putting in a PHQ-9 along with a QPD because primarily we wanted to be able to figure out how to get a PHQ-9 score out of people who did a QPD, so that you could actually translate between the two. And so that's what the data set was originally there for. But it also turns out it's a great way to go in and look at this concept of pre-screening versus not. And so we got these 2,495 cases, and we're going to look at, what really happens when you do that PHQ-9 screening relative to what the QPD is going to show. And it's going to get into all your psychological domains and all that kind of stuff. And so then we're going to go on and calculate our false positives, our false negatives, and then just to get to this financial side of this thing to really drive it home, we get into time calculations and then get into your cost savings associated with using an in-depth assessment in an automated fashion, which is really where everybody should be at. So here's the assessment. This is a basically a positive QPD is when one of the domains scores, and so the major domains it's covering are depression, manic episode, anxiety, panic disorder, PTSD, eating disorder, substance use, and somatization. And it also pulls out. Basically lays all those out, kind of like almost like blood work. It kind of shows out of range what's a normal range is and so forth, and flags what's outside the range. And then it goes through and actually pulls up some provisional diagnoses, which you can relate directly across to DSM-5 sort of categories on that. It comes back with a bunch of symptoms individually laid out for those areas that are outside the normal range and so forth. And then it'll also track on anxiety and depression and so forth, so that you can kind of see what's going on for a little bit of an outcome in patient management side of things. But the big thing here is that what we ended up doing is we just said any one of those 7, 8 domains there, any one of those domains out of range, basically outside the normal range, would end up being essentially in a positive for a QPD. And so we kind of took that number and pushed it against everything else. So here's some of our results. The first most obvious thing you look at there is that the QPD was 44% of the time it came up positive. So, that's a little tough population, but not outrageous. That's actually pretty typical in a lot of these different sort of settings. So if we look at our the normal cut score on a PHQ-9 of, say, basically greater than 9, so, greater than or equal to 10, came in at like 31%, which, maybe is a little high, but it's reasonable. And then we went through and did some cut scores that, basically PHQ-2 going from essentially a score of 2 down to 1 down to 0. And so what you ended up with is, once again, about 31% of the, at a PHQ greater than 2, a PHQ-2 greater than 2, you end up with about 31%. So you're kind of in the ballpark of the PHQ-9, but as we get into the details, we'll see that you're kind of missing a lot more with the PHQ-2. As you go higher in the PHQ-2 score, what we'll show then is that you're picking up more of the QPD data, but it turns out you're triggering a lot more false positive information. But so anyway, there's just your kind of your ballpark, and pretty typical in these types of environments. So now we get into, let's look at basically our false positives and our false negatives. And so if you're looking at a PHQ-9 of greater than 9, you're not doing too bad. You got a 3% false positive rate relative to the QPD. So you're kind of triggering on stuff that the QPD would have got a little more specific about and kind of pushed away. But the thing that you're missing there, if you look at that, almost 16% of the time, QPD is coming up with something that PHQ-9 is not even putting out there. So you got these false negatives. So that's not a good situation. If you go the other way and you go all the way down, and let's say you just use a PHQ-2 greater than 0. In other words, if they assert on anything above the first answer, then you end up with 25% of the time your false positives, but you triggered out to a large portion of the QPD data, down to like 4% of the time. So if you want to tolerate that high level, you can actually get into, it'll trigger you into more things that the QPD is going to find, but probably not your best bet as to how to push forward with that. But the big things to see here, obviously, is there's this trade-off between false positive and false negatives just based on where you put your cut scores. But the biggest problem here is that even in your best case with the PHQ-9 greater than 9, you're wrong 19% of the time when you add the two together. And if you do your PHQ-2, you're 26, 25, and 29% of the time, respectively. And so you're missing a lot. You're creating and the problem with any of these false positives is either one, you're missing, which is really hurting the patient, or you're false negative, which means you're just putting more time on staff to go in and try to figure out what's going on. So not good in terms of this type of stuff. So, even as just a detection tool, just to simply say, hey, raise the flag, not necessarily your best bet. So let's put some numbers to that in terms of what are your costs? What kind of labor did you end up creating out of the whole process? So I went in here and I just took the basic cut scores and the numbers that came out. Assume that you always have to give that QPD because that PHQ, whether it's a 2 or a 9, you're always going to have to give that. So you got 2,495 of those every single time. And then you got to look at, all right, so for each one of those, let's assume, a staff person takes at least a minute to administer it, basically calculate the score, and then turn around and enter it into the EMR. I would say that in most cases, probably more than that, but let's just use that for a nice conservative number and so forth and push that in. Then we looked at what's going to happen from the behavioral health therapist side of this thing. Whoever's going to have to follow up on the information and so forth. And no matter what, you basically any time that you trigger a PHQ-9, you're going to have to give that QPD. So we can assign 10 minutes of time just on average, and I think it's probably more than that. But you can set an average of 10 minutes is fine. For every time that you trigger positive, whether you're using the PHQ-9 or the PHQ-2 or whatever kind of cut scores you want to put on there. And then we took some really conservative numbers on staff time. So, $40 per hour with benefits. In project management, we call that burdened rates and so forth. For the behavioral health therapist, we put it out there at $60 per hour, which is probably quite reasonable as far as that side goes. And then the basic cost for using paper, just the procurement, printing, handing out, and all that kind of stuff, just handling of paper and disposal of paper and so forth. We're just saying 15 cents per any time that you give that PHQ-9 when using paper to go through the process. So that's how you manage that manual side of the whole thing. So if you put those assumptions in there, what you see are, well, if with your BHQ-9 score of greater than 9, you're doing like 130 hours of behavioral health therapist time to just follow up on information. And when you run those numbers out, your cost comes in just a little bit under 10 grand. And it's a very similar sort of thing if you're using that PHQ-2 with a cut score greater than 2. Once again, you're coming in, just a little bit under 10 grand. But if you want to go a little bit deeper and try to pick up some of the stuff that the QPD that would normally have pulled out for you and so forth, so you basically run those cut scores down a little bit lower, then you're basically false positive, but getting somebody to get in and look at that other information. So you start running up to like the 15 grand and the 18 grand sort of region. Meanwhile, if you come back to doing this electronically, which the nice thing about the QPD, it is self-report, and if you do it, it's actually so complex that you could never do it on paper in the first place. So actually back when we first did these back in 95, we actually had to invent the tablet to do it electronically with Kaiser here in Colorado and so forth. And so that whole electronic processing It is incredibly cost effective, I guess the best way to say it. So if you start running those numbers out, a QPD does have a license fee, so in volume you're probably down to like $1.50 per administration. And from the electronic assessment side of this thing, it's just us getting our transaction fees from patient tool side. It's basically you're probably down 38 cents per administration for a reasonable sort of volume. You can get those numbers much lower, and if you do like very sparse sort of things, they'll probably get higher than that. But it's a very reasonable number to use. And so if you just start running those numbers in there, then you look at the cost of electronic, and it's really significantly lower. So you've saved yourself a ton of time, and you've saved yourself a ton of money in the process of actually doing this in-depth electronic assessment on top of the PHQ-9. So use that PHQ-9 as a pre-screener. So let's look at those primary results. So it's basically this concept that the PHQ-9 is following the DSM-5. It required, electronic administration. It was just too complex even to train somebody to administer it properly. So it has to be done electronically. But the cool thing there is that you're also going to pick up your PHQs. You're automatically going to trigger electronically. So there's no real staff time involved in the whole process. So you automatically pre-screen and do your initial assessment all in just one session. And it's relatively quick. I mean, the QPD on average runs maybe 6.5 minutes when it actually triggers. And then if you're not triggering it all the time, obviously, then you have much shorter sort of things, just the amount of time it takes to do that PHQ-9 or that PHQ-2 that you're doing. So, the next result is, trade-offs in your cut scores. So, you got to figure out how much of that QPD do you want to try grabbing with that PHQ-2. And so, potentially you over-detect, which since you're using a PHQ-9, basically a QPD now to do your follow-up, you're not driving up the cost, you're not driving up your labor. It's not an unreasonable sort of thing that you just run that PHQ-2 score down a little bit lower to pick up more things that you'll then get with your QPD, making that handle the specificity of the situation. So then finally, the alternative to this whole thing is that we do know that depression is generally around 70% comorbid with anxiety. And so what you're seeing then is that probably a lot of the stuff that you're missing is anxiety-based. It's not even showing up as depression. And so if you were to throw in, say, a GAD-7 as a pre-screen or even a GAD-2 as a pre-screen and maybe kind of let it trigger a little bit higher, you might find there's a combination in between the two. And in fact, what we've done is we've pushed back on the author of the QPD and kind of got them to come up with a pre-screen that they think that works. And it's got 3 questions from the PHQ-9 and 2 questions from the GAD-2, and you use that to pre-screen into the QPD, which then makes the QPD much more reasonable to use. Up until recently, it's always been you basically wait for a medical provider to say, hey, I got some stuff going on here that I just don't want to get into, so I'll just hand them a tablet, have them take the QPD, get my results back, and then proceed with how do we go forward. What's kind of fun here is let's go back and break this down in terms of this missing information. So there's 3 kinds of information that you're missing here. One is, what's your underlying population? So of that 44% of positive QPDs, what does that break down to? And so you can see down the left-hand column there, it's everything from major depression, dysthymia, all the way down into, your PTSD, down into even suicidality and so forth. And so what you see is let's kind of break into 2 categories. There's the depression-related and more anxiety-related sort of in-depth sort of pieces that you're looking at there. And so you can see how if you break those out, you can see what you're getting into. But, the big thing here is that when the QPD is used, one of the arguments you use is, one, you should not be going out there and obviously overprescribing or antidepressants for people who are bipolar. So you really want to know that piece. That was one of the early on arguments. And the other one is that, basically if you're depressed, but you're locked in a PTSD sort of situation, if you don't treat the PTSD, you'll just stay on antidepressants forever sort of thing. And so you really want to know what's going down inside when you do that sort of stuff. So anyway, so now we get over to, if we look at the center column there, that we're basically looking at something that triggered the PHQ-9. So when you trigger the PHQ-9, all you're getting right now is simply that distress level, and basically you took their temperature, their psychological temperature. But if you break that down, like if you had all this other information available to you, you can see that, when you would trigger on the PHQ-9 coming up positive, then, 61% of the time, okay, that is major depression. But now you start breaking it out into other types of depression. You start looking at what's the mania associated with that. What's the anxiety that may have been related to that? What's the PTSD? 55% of the time you have PTSD in the whole process. Anxiety secondary to depression is a big one. Somatization down there. So, there's a bunch of other categories of things that if you had that information, it makes it much more actionable in terms of how you refer. And in the case, that's if you have to go to especially psychology and so forth. But, from basically from a behavioral health therapist perspective, if you had that report in front of you, then you can sit back and go, oh, let's just validate what the provisional diagnosis came up with and from the QPD and say, okay, let's verify it's there. And then we can actually get past that initial assessment and get into doing some initial, interventions and so forth. So, those brief sort of activities and so forth that you can do that are quite effective. So, you get directly to what you need to be doing as opposed to having to go through this in-depth assessment sort of process. And I suspect that, as you go through that process, you're not even picking everything up. The QPD is quite thorough in terms of what it gets into. So anyway, that's the information you're missing when you do come up with a positive PHQ-9. And then finally, you look at, what was the stuff that you missed when you came up false negative on the PHQ-9? And so you got a whole breakout of things there that you're like, what are you missing? And you can see a lot of that's anxiety and PTSD related and so forth. So it's just kind of interesting to take a hard look at what are you not getting that you could get, with the same amount of effort as you're doing right now to get just a PHQ-9 score. So anyway, just thoughts for you on why you might want to automate and so forth. So now that we've taken a look at the missing information, let's think about some other considerations associated with this, and kind of target these towards the integrative behavioral health therapist. So the big complaint in this particular arena is that it's difficult to get people to come back. Basically your one and done is what a lot of people will say. Getting them to come back even for a follow-up with a behavioral health consultant or a therapist, much less trying to get them over to specialty psych. And so your problem here is that you want to get as much done in that first meeting that you finally have something to work on. So, it's this whole problem of, we see that basically the advice that's being given to therapists is that, you need to start getting into some of that initial assessment right during that first warm handoff as opposed to just kind of creating the relationship, unfortunately. Because, the odds are you're not going to be able to see that person again anyway. And so what we would say is if you use the QPD here, you even take that a step further in that you're actually getting that initial assessment done by the patient before they even talk to you. And now when you're looking at that, all you really have to do is just, essentially verify what that provisional diagnosis is that came from the QPD. And now you can actually get into some brief intervention and start some initial work and so forth. And, you basically move it up another level in terms of your ability to get to the patient and get some good intervention going. The next area to think about is, with these value-based metrics that you're trying to get into, one of the things that we hear a lot is that people having a hard time getting under that 30-minute session time. So if you could basically have that QPD do at least 10 minutes worth of assessment for you before you even get in front of the patient, now you've basically knocked a ton of time out, and time is incredibly important, and you're already being pulled in a bazillion different directions. With 44% of your population having issues, you got plenty to work on. So, anytime the value of time is incredibly important here. And so, it's a big thing to think about is if you start using some automation to get some of that initial assessment work done for you, it can really help your process along. And then the other thing that the initial, back in the day when we integrated behavioral kind of started out, it was kind of this idea that you were going to move your psychologists down into your clinics. And, obviously you didn't have enough resources at that point, and they've since gone broadened things out and said, let's go after behavioral issues, and bring in behavioral health therapists. You do some level of getting into the hardcore psych, but you're not really treating the hardcore sort of things at that level. You're still referring off to specialty psychology and so forth. But in that whole process, though, the idea was that you when you didn't have enough resource to go around, you ended up becoming a consultant, because you originally called behavioral health consultants, and the idea was that you're basically bringing the medical providers along, and a lot of the handling of the behavioral health sort of issues or behavioral issues and so forth was actually being trained into the medical providers. And so it was kind of this idea that you're trying to get this I shouldn't say symbiotic, but basically a very close relationship with your medical providers. But what you find instead is that you're kind of still keeping barriers up between the two. And one of the places, one of the interesting observations of that was actually in this reference we have down here for basically people using a PHQ-2 in medical settings and coming up positive, and 95% of the time they didn't refer on. You've kind of lost your medical side. They didn't think there's anything useful that's going to come out of the information. I mean, you're not engaging that medical side. So if you think about something like the QPD, once again, we're on the systemic type of issues here, but that it's designed for medical providers. It's written for DSM-5, so you can have a common language. It's laid out as like blood work, but the whole idea there is you're engaging the medical side of this whole thing, and you can actually get them involved in the process a whole lot better. And so, there's a whole aspect of that going on that people just don't really realize. It makes it into a better communication tool between the two when you use something like that. And then we look over here at the, once you're doing, the interesting thing about the QPD is it was so complex that you couldn't train somebody to give it properly. But what it's basically doing is it's going through and looking around a little bit and asking some questions about depression, and if you're answering above a certain threshold of response, then it kind of goes deeper on on whatever topic you mean. It's basically bouncing in and bouncing out, and so it's kind of this really dynamic sort of process that it's going through. But the result of all that was that you had to do it electronically, and so we actually ended up creating the tablets to do it back in '95, back before there were tablets available and that was kind of the primary reason why we ended up with a QPD inside of our tablets. But it's doing that electronically now, we learned some interesting things. It's one, patients are a great resource. Patients are doing all your data entry for you, because QPD is a self-report sort of deal. And now you can, now that you got it electronically, it's real easy to interface that into your EMR. I mean, the biggest problem with the EMR integration is figuring out where to put the data. It's not the transfer process. That's an easy sort of thing. So, it kind of forces you over this electronic administration concept, and that's like the only way to really integrate it at this point. And you go through electronic administration and do some automation. So anyway, just other systemic sort of things to think about associated with what the study kind of tells you. So, the big thing that we come back to in this whole process is that you're really trying to figure out how to turn screening into a patient interview. And so, what we're able to see out of this whole thing is, the PHQ-9 is a measure of distress. So it does a good job of that. And so if you're going to use it for tracking, for, say, in a registry, or for doing outcomes and so forth, I mean, it kind of makes sense in those particular situations. But, you're dealing with a whole lot of other stuff here. You're working into the biopsychosocial model. So it's not just, stuff that you could screen around pain or around chronic conditions and so forth. You're doing all your psychological sort of things. And so QPD is a great example of the depth of information you get into there. But being a behavioral health therapist, then there's a bunch of behavioral sort of things. Maybe you want to be looking more at family relationships. Maybe you want to be looking at weight control problems. Maybe you want, whatever you want to be looking at. And then, this whole social determinants of health sort of movement. Everybody's starting to understand that you're really involved with, what's going on around you, the family situation and the community situation. I mean, the basic safety sort of issues and so forth. And so there's just a whole breadth of information that you could be pulling out of this interview. And the PHQ-9 is just kind of saying, oh, I got your temperature and I'm throwing a flag. And I mean, that's the level of detection that you're doing there, where a real interview would actually break all that information out. So you need to think about, it's not, you want much greater breadth. You want to be integrated with the medical side of this thing. So you need to be asking about medical sort of things along with your psychological or behavioral sort of things. And you want to be going after the social determinants and so forth, and start getting into management of patients and so forth. So, lots of information to be had, and your patients are essentially a resource to give you that information if you just go to them and get the information out of them. And automating that process, there's no extra cost associated, really. It's just, now I got better information. And so, if you think about the real functional sort of things you're doing there, it's really this concept of detection. Then there's this whole assessment sort of thing. And then it's the monitoring. It's basically, what are the protocols you're following up with information on these people? When do you go back in and assess deeply again and so forth? So there's a whole set of logic around what do you do when, and what do you measure, and all that kind of stuff. But once you get all that, once you get that greater breadth of information, I mean, having things electronically, then, you're going to also be supporting outcomes. So, maybe not just track the PHQ on your outcome. Maybe track a GAD, go off and measure PTSD. I mean, there's all sorts of, depending on what you're working on and so forth, there are all sorts of measures that you can track a whole lot better than just the PHQ-9. So, registry tracking, outcomes, then you start getting into, look at that breadth of information with that QPD, and just in terms of population management, in terms of what you're getting into. And then, if you have a ready source of electronic information that's coming out of this patient interview, that you can do practice-based research. You can do all of your quality improvement sort of things. There's just once you go electronic and get real data, and don't trap it all inside your, expect it all to be put inside your EMR, which we'll get into in the next webinar. But basically, there's a ton to be done here, and the big message here is that if you do a good patient interview, then you're improving the quality, you're improving the performance, and it's a great tool that you need to be putting into your process. So, particular webinar, we went after basically CJ Peek's first worldview of the clinical side of this whole thing, and just tried to make it very clear there's a lot more information to be had there, and it can be used a whole lot better than what's going on right now. But, obviously it's not something that you can just implement manually anymore. You're going to have to go past that. And so the reality is that actually simplifies your process. You're actually going to save time and cost. And so we'll get into how that whole thing works and get into that whole operational component when we go on to webinar number 2. So please scroll down and leave a comment for us. The links to other webinars are down there inside the series as far as the other webinars. And then, hopefully we'll see you in webinar number 2. Thank you very much for your time.